Hello everybody and welcome back to my vlog. This week I'm going to cover something called diverticular disease, and I'm doing it for a patient of mine. And this is a patient who was recently diagnosed and has lots of things going on now after the initial time that she was diagnosed, and it made me realise that it's a largely ignored disease in GP land until we actually come across it, and that I needed to know more, so that's what I'm doing today, and hopefully then you'll know more. So the place we need to start is, what is diverticular disease? Well, diverticular disease and diverticulitis are two related conditions that happen in the colon or the large bowel. So diverticular, which is where the disease name comes from, is, if you consider this is your large bowel, a lot bigger than that obviously, but let's say that's a tube, and small pouches develop poking outwards from the bowel. And those pouches, once present, give you the diagnosis of diverticular disease. They're little pockets of bowel. So diverticulitis is inflammation of those pockets, and it's this inflammation that causes pain and lots of the other symptoms that people get with a flare of diverticulitis. Diverticulitis, one of those words again. So you most often find these pockets or pouches in the descending colon. So that's the big bit of colon on the left side of your body, from just under your ribs down to your anus, where the poo comes out. So that's your descending colon. So who gets diverticular disease? Well, it increases with age, that's for sure, and it's quite rare in people under 40. But having said that, if you do get diverticular disease in younger patients, it runs a more virulent course, and there's a much higher risk of complications. Interestingly, it's rare in rural Africa and Asia, and it's most common in the USA, Europe and Australia. And 50% of people by the age of 50 have got diverticular disease, and 70% by the age of 80. So you can see, as age goes up, so does the prevalence of having it. 75% of those people, however, so 3 in 4, don't have any symptoms at all and would never know that they actually had diverticular in their bowel. 25% have at least one episode of diverticulitis, the inflammation. So what are the risks for developing diverticular disease? Well, obviously we've already said being over 50 or advancing age. Constipation is the main risk, and we'll talk about that. Smoking. Being overweight or obese, especially in younger people. Using NSAIDs, so that's ibuprofen, diclofenac, naproxen, paracetamol, and having a low fibre diet. And obviously it's the low fibre diet that leads to constipation quite often. And genetics. You're more likely to have diverticular disease if your mother or father had it. Excuse me. So what are the symptoms? Well, for most people, as we've said, there are no symptoms. So that's the good news about it. So in diverticular disease, so where you've just got the pockets, not inflammation, you can have pain down on the lower left side of your tummy, which comes and goes, and it gets worse during or after eating. Feeling bloated, having mucus in your poo, constipation or diarrhoea, or a combination of both, switching between, and tenderness when you press down in that lower left area. And that was the thing I didn't realise, that even in between bouts of diverticulitis, just having the pockets for some patients is enough to cause that tenderness. And then diverticulitis, which is inflammation of those pockets. So then you have more severe and constant pain. Usually, as I said, it's in that left lower side of the tummy, but interestingly in Asian patients, it can appear on the right side of the tummy. A change in your bowel habit, so if you're normally constipated you might get diarrhoea and vice versa. Having a fever over 38 degrees, being generally unwell, tired, nausea, vomiting, loss of appetite, having a palpable mass, so when you feel the tummy you can feel a lump, and having blood in your poo. So as you can see, diverticulitis just ramps up the symptoms and becomes more serious. So how does one get diagnosed with diverticular disease or diverticulitis? So generally these patients initially present to their GP, and the GP will do a thorough history and examination. and they'll try and make sure that, excuse me, we're not dealing with another disease. I'm so sorry. So make sure we're not dealing with irritable bowel syndrome, celiac, Crohn's disease, ischemic colitis, or bowel cancer. When the GP examines you, you might be tender down in the left-hand side of your tummy. There might be a mass that they can feel. They will need to put a finger inside your bottom where the poo comes out, and that might be a tender examination. If they did bloods, they should normally be normal in diverticular disease, but not in diverticulitis, where you will show signs of infection. They might send you for what's called a barium enema, where you have a special substance put inside your rectum into your last bit of your colon, and then an X-ray has a look at it, and it goes into the pockets and can show the pockets, and it therefore identifies pockets and where they are, but it doesn't tell you whether or not there's any relevance of that to you clinically. You can have a colonoscopy, which is a camera, again up the backside, which can be more diagnostic and tell you about clinical relevance. So what are the complications of having diverticular disease? So you can develop abscesses, so like boils, but inside your abdomen, and these can be really serious. They can lead to peritonitis, so poison inside your stomach essentially, or not your stomach, your abdomen, the area where all of your organs sit, and this can lead to sepsis, and ultimately that can actually cause death, as we know. Perforation of your bowel, so one of the pockets can actually burst, which then makes a hole in your colon, and that's actually what leads to the peritonitis. Poo seeps out of the colon into the space in your tummy. A fistula. So a fistula is a connection between different body parts that there shouldn't normally be, and it allows poo to travel into areas where it shouldn't be. A bowel obstruction. So your bowel gets totally blocked, so you can no longer move anything along it, and that's a life-threatening complication. Or hemorrhage. They can bleed and you can lose lots of blood. So as you can see, there are some serious complications. So what further investigations might happen when it's suspected that you have diverticular disease or diverticulitis? Well, a chest x-ray, which might sound odd as we're talking about something lower down, could show air underneath your diaphragm from a perforation, and that's called a pneumoperitoneum. That would be a very serious finding, and obviously that would only be done in an acute setting where you've been admitted because of complications. An X-ray of your tummy may show small or large bowel dilatation, so your bowel's bigger than it should be, which may also show an obstruction because air is getting trapped. That could also indicate an abscess or show an abscess. You could have a CT scan with some dye to show contrast, which would easily and most likely diagnose an abscess. For fistulas, the best way to investigate those is by a cystoscopy, which is where a camera goes into your bladder and up through the different tubes there, a cystography, contrast x-rays, or dye put in, contrast with dimethylene blue. And then if you've got a hemorrhage, a flexible sigmoidoscopy. So again, that's going into the bowel and having a look at that last portion of bowel to see what's going on, where you're bleeding from. So as you can see, there are lots of different diagnostic tools that a GP and a hospital would use between them to diagnose what's going on, depending on exactly what's happening to you. So what is the treatment if you don't have symptoms? So if you have uncomplicated disease or you don't have any symptoms at all, the most important thing is you have a high fibre diet so that you keep the stools soft and you keep them moving. We need to warn patients, even if they don't have symptoms or complications, that there is a risk of perforation if they use opioid medicines, so codeine, dihydrocodeine, all of those medications which are quite common, or NSAIDs, ibuprofen, diclofenac, naproxen. So it's best to avoid those and stick with paracetamol. There is some evidence that calcium channel blockers, which are blood pressure tablets, are associated with a reduction in perforation of the bowel and complications, but there isn't enough evidence yet for those to be used routinely. And there's no need, as I said, for any pain relief apart from paracetamol at that stage, and usually not even paracetamol because you're not getting symptoms. But if you are getting symptoms from diverticular disease, a high fibre diet, bulk forming laxatives, keeping your fluid intake high to make sure that you're well hydrated. If you have blood loss, sometimes you might need to go into hospital to have a transfusion. Antispasmodic medications can help with pain, so to just make sure that the gut isn't contracting on itself and going into spasm. And we don't recommend osmotic laxatives, so laxatives that attract water. And as I said before, paracetamol for pain relief. If you have diverticulitis and that's been diagnosed by your GP and the decision has been taken to be treated at home, then initially you'll have a broad spectrum antibiotic, so something that really does cover off more than one bacteria. So that could be, for example, coamoxiclav, or it could be a combination of metronidazole and ciprofloxacin if you have an allergy to penicillin. Paracetamol for pain relief, and at that point just clear liquids for your diet. Take all solids out and no high fibre at this stage, just clear liquids. As your symptoms improve, you can gradually and gently start to reintroduce solid food, but carefully over 2 to 3 days so that the bowel gets used to it. There is some evidence that mesalazine is better at improving symptoms and bowel habit and preventing recurrence of diverticulitis than antibiotics alone, but that's likely to be something which is instigated by secondary care gastroenterologists than just at your GP alone. If, however, you are so poorly with diverticulitis, and this is always the judgment that a GP has to make because patients do get very sick, and as we've already seen, the complications can be quite severe, you may need hospital admission. If you're not able to keep your hydration up, not keep enough down, if your pain is not managed by paracetamol alone, if you've got rectal bleeding, so blood from your bottom, which needs a transfusion because it's so severe, or there's any signs that you've perforated, as I've said before, the hole in the bowel, or you're septic, you will need to go to hospital. If your GP suspects that you have an abscess or a fistula, you will need to go to hospital. And if your symptoms are not getting better within 48 hours, again, it's off to hospital, I'm afraid. If you're very frail or you've got other diseases that make you at higher risk of complications, then again, hospital is the only way. Some people require surgery. So 15 to 30% of people who are admitted because of sepsis, peritonitis, a fistula, an obstruction need surgery. And sometimes there's questions over whether or not there is an underlying cancer. And so those people will need surgery. Surgery is often used for recurrence, but it's important to note that most patients who end up having surgery don't even know they've got diverticular disease and it's their first presentation. So how do you manage these complications, which are quite vast? So if you have an abscess, you'll need antibiotics and complete bowel rest, so no food going into your bowel. And if it isn't resolving with that treatment, you'll have to have a CT-guided drainage over surgery initially. But if complicated, you may need surgery to take away that part of your bowel. If you've got a fistula, so this connection between body parts, if it's going from your colon to your bladder, you may need, again, surgery to take that fistula away and close it. If it's going between your bladder and your bowel and your vagina, you may need a vaginal repair and surgical resection. If you have an obstruction, if it's the small bowel, it may improve with bowel rest and conservative treatment. But if you've got a situation where the doctors can't decide whether or not there might be an underlying cancer, and we can't exclude that, then you will need surgery to have a look, and you may need an endoscopic balloon dilatation. So that's when a special camera goes in and a balloon goes into the area where you've got a narrowing and it's blown up to stretch that narrowing. So that's called a stricture, and that's when we would use that. Sometimes where the stricture or the narrowing of the bowel is, a stent can be used to go in and again hold that part of the bowel open that was previously closed. You do need to have some bowel preparation for that, where your bowel is emptied out, and you may need a resection of bowel. So it's complicated, and this is where the gastroenterologists and surgeons take over, because obviously this is well outside the scope of a GP surgery. But these are all complications that need to be addressed quickly. And if you've got a hemorrhage, as I've said, that looks like you might need a transfusion, you'll need fluid and blood. You might need special drugs called vasopressin to actually stop the bleeding. And sometimes you can have angiography, where a tube goes in and actually has a look with a very fine camera, similar to what they do for heart attacks, to actually see what's going on and to get you ready for surgery to find out where the bleeding is. Sometimes we can actually embolise the bleeding, so seal it off with heat, and if all of those things fail, then you need surgery to stop that hemorrhaging as well. So as you can see, there are lots of really complicated things that can go wrong with diverticular disease and then diverticulitis. But it's only the minority of patients where this happens, so don't be terrified. It's not going to happen to most people with diverticular disease. So how do you prevent it? So dietary fibre is the key. As much dietary fibre as you can actually get into you and tolerate, to prevent the development of diverticular in the first place, but then once you've actually got them, to actually minimise the chances of complications or diverticulitis. Exercise does help prevent development, but that's probably because exercise helps bowel movements and to prevent constipation. Because the final point I have is to just avoid constipation at all costs. So what's the long-term outlook for people with this disease? 75%, as I've said, never get symptoms, so it's good. Mortality and morbidity, so problems that lead to disability or even death, are related to complications and only occur in 10 to 20% of sufferers. And so don't forget that only 25% of people actually have symptoms. So that's a really small amount of people that get the complications during their lifetime. Most complications are associated with the initial attack of diverticulitis. And after that, it tends to run a more benign course. So things tend to get better after that first attack. So hopefully I've given you a snapshot of what is a difficult disease and can be really, really difficult for people to manage, but can be managed. So this is diverticular disease and diverticulitis. I'm going to put some links up afterwards to some information from NICE and some other support groups for people with these diseases so that they can see what other people do. And hopefully that'll be a big help. But the most important message from today is, from a very young age, avoid constipation. And even if you get diagnosed with diverticular disease, carry on trying to avoid constipation at all costs. That's the message. If you've got any questions for me, please ask them. I'll always answer them. And if you've got any suggestions for me for future vlogs, I'll always do them for you as well. So please feel free to make those suggestions as well. So I hope that helped. Take care. See you soon. And as ever, thanks for watching.